Now, in this part, we'll talk a little bit about the relationship between the hypothalamus and the pituitary gland. We will also discuss the thyroid gland. So we kind of agreed that a hormone that controls the secretion of another hormone is referred to as a tropic hormone. Most of these tropic hormones are secreted by the hypothalamus, and they are going to control the release of hormones from the anterior pituitary gland. They can also lead to increase in size of the gland, and we call that trophy. So hypertrophy, for example, would be the increase in the size of the gland. Examples of these tropic hormones are TRH, that stands for thyrotropin releasing hormone. And again, that's a hormone made by the hypothalamus, and it will stimulate the anterior pituitary gland to make hormone known as TSH, or thyroid stimulating hormone. CRH stands for corticotropin releasing hormone, and that is going to be related to the release of cortisol. So let's take a look at the summary of the hypothalamic anterior pituitary gland system. So notice this is the anterior gland. We have not discussed the posterior gland yet. So that yellow bar on the top represents the hormones coming out of the hypothalamus. This orange bar represents the hormones coming out of the anterior pituitary gland. And then down here are different target cells. We'll take them one at a time. So this right here stands for gonadotropin releasing hormone, which means that it is related to the gonads. Gonadotropin releasing hormone reaches the anterior pituitary gland and stimulates it to release follicle stimulating hormone and luteinizing hormone. Those two hormones are made whether in the male or female system, will circulate through the bloodstream to reach the gonads. So it'll lead to germ cell development, so the female to make an ovum and the male to make sperms, while it also increase the secretion of their hormones. So females will start making estradiol and progesterone, while males will start making testosterone. The next set of hormones are related to growth hormone. We've got growth hormone releasing hormone and somatostatin. Growth hormone releasing hormone, as you can see, is stimulatory, while somatostatin is inhibitory. These two hormones will either stimulate or inhibit the anterior pituitary to release growth hormone. If growth hormone is stimulated, it will reach its target cells, for example, the liver cells, to secrete IGF-1, and we'll talk about that more in detail later. Or it'll go to other tissues in order to increase protein synthesis and to affect carbohydrate and lipid metabolism. The third hormone coming out, or the fourth, I guess, from the hypothalamus is thyroid releasing hormone. And that will stimulate the anterior pituitary to make TSH, or thyroid stimulating hormone. Its target cell would be the thyroid tissue. It'll stimulate the thyroid to secrete thyroxine and triiodothyronine. So thyroxine is basically two hormones, T3 and T4. DA, or dopamine, that is going to inhibit the formation or the secretion of prolactin from the anterior pituitary. The target of prolactin are breasts, so it'll lead to breast development and milk production in women when needed. CRH, or corticotropin releasing hormone, that will stimulate the anterior pituitary to make ACTH, and that is adrenocorticotropic hormone, and that will stimulate the adrenal cortex to make cortisol. So it is kind of a hierarchy of events where your hypothalamus affects the anterior pituitary, either stimulating it or inhibiting it from making hormones. If it stimulates it to make hormones, those hormones are going to reach their targets and produce different effects. You will see here that we only have inhibitory hormones 4 things that we do not need throughout our life. Okay, so growth hormone, for example, and prolactin are only needed during certain parts of our lifespan. And that is why both of them have an inhibitory hormone that comes out of the hypothalamus. Now the connection between the hypothalamus and the posterior pituitary. Well, the posterior pituitary does not really synthesize its own hormones. Okay, it will store it and secrete them. So oxytocin and ADH, or antidiuretic hormone, are actually made in the hypothalamus. And again, they are going to reach the posterior pituitary and be secreted from there. Oxytocin's action is related to the milk ejection reflex during breastfeeding. It also helps in the contraction of the smooth muscles of the uterus during delivery. And it also was found to have a relationship between that emotional bonding between mom and baby. Antidiuretic hormone has another name, an older name known as vasopressin, but if you know both of them, that'll help in remembering the action of that hormone. So the overall goal of that hormone is to increase blood pressure. So it'll lead to antidiuresis. Okay, so it regulates water balance and osmolarity, and vasopressin, which means to constrict the blood vessels. So if you do both of these things, where you constrict the blood vessels and you decrease the amount of urine being made, okay, that will eventually lead to increase of blood pressure. Here you can see the presentation or representation of the relationship between the hypothalamus on the top and the pituitary gland right here. Remember, the pituitary gland is found in a bone socket found in the cranial cavity known as the sella turcica. Right there, sella turcica, which literally translates into the Turkish saddle. The hypothalamus, you can see here its cells, and it is connected to the pituitary gland through what is known as the infundibulum. The infundibulum has different things passing through it. So we'll talk first about the connection between the hypothalamus and the anterior pituitary. You can see that there are these blood vessels, and those are known as the hypophyseal portal vessels. A portal circulation means connection between arterioles through capillaries. So we all know that an arteriole will eventually become a capillary and then become a venule. In a portal circulation, that's not how it works. In a portal circulation, it goes arteriole, capillary, and then another arteriole. We have different portal circulations. For example, you see one right here. There's portal circulation in the liver. There's another portal circulation that we'll talk about when we get to the kidneys. So again, portal just means connection between arterioles through capillaries. And because it's between the hypothalamus and the pituitary, which is nicknamed the hypophyseal, these portal vessels are known as the hypothalamic-hypophyseal portal circulation, or portal vessels. And the hormones that are made in the hypothalamus that are supposed to either stimulate or inhibit the anterior pituitary are going to reach them through that portal circulation. Now for the connection between the hypothalamus and the posterior pituitary, well, we said that those hormones are actually made inside of the hypothalamus. The hypothalamus have cells that are known as the neuroendocrine cells. They are nerves, okay, but they are specialized nerves in what makes them special is that they can make hormones. The hormones that they make are either your ADH, which is the antidiuretic hormone, or oxytocin. And again, you see it that it'll go down those axons to be released from the posterior pituitary. Okay, so when we always say, the posterior pituitary secretes ADH and oxytocin, that was kind of like a lie-ish kind of thing, because it's really not made by the posterior pituitary. They're made by the neuroendocrine cells found in the hypothalamus. Now, what are the different kinds of endocrine disorders? We have either hypo or hyper secretion, which are either making too little or too much hormone. Or the levels of hormones are fine, but there's a problem in the target cells, a problem most probably in the receptors. So it's either hypo-responsiveness or hyper-responsiveness. So hyper-responsiveness means that there's a decreased response at the target cell level to the hormone. Hyper-responsiveness is the opposite, where there's an increased response at the target cells to these hormones. So again, the level of hormones could be normal. It's just something is going on at the level of the target cell where they're either not responding enough or responding too much. Now, down over to your thyroid gland. The thyroid gland is a gland that looks like a butterfly. It's found in the anterior portion of the neck. It hugs the trachea. It's found right underneath the larynx. It is made out of two lobes, a right and a left lobe, right and left, and it is connected in the middle, what is known as an isthmus. This anatomy kind of explains some of the symptoms if somebody gets hyperthyroid or goiter, which is an enlarged thyroid gland. They would have, they could have difficulty in breathing because of the compression of the trachea. If it involves, compresses the larynx, they can also have change in their voice due to that. And if you look at the microscopic picture, you will find these little follicles, or not little, big follicles, and the follicle has a lot of pink colloid, and that is where the thyroxine hormone is stored. These thyroid follicles are lined with follicular cells. These follicular cells are going to produce thyroxine. And then there are scattered in between these follicular cells, we have what are known as parafollicular cells. Okay, also nicknamed C cells, and those secrete calcitonin. Calcitonin is related to the homeostasis of calcium, and we'll talk about that towards the end of the chapter. Okay, so again, your follicular cells secrete T3 and T4, which are the two different kinds of thyroid hormones, while your parafollicular cells secrete calcitonin. We store thyroxine in that colloid that is found within the follicles. So how do we make thyroxine? Okay, the follicular cells, so I'm going to talk about it here, and then we'll go to the slide in the image, in the next slide, to better understand it again. So your follicular cells are going to trap negative iodide ions. So T3 and T4, the letter 3 and 4 actually tells us how many iodide ions are found in there. So the follicular cells, these cells right here, are going to trap negative iodide ions, okay, and then they're going to transport them into the cell. They are co-transported with sodium, and sodium will then get pumped back out of the cell through the sodium-potassium pump. What happens to that iodide? Well, now that's in the follicular cell, it will be transported into the follicle through another protein known as pendrin. Pendrin is a protein transporter. It transports both chloride and iodide, and because it does not depend on sodium, it is called a sodium-independent chloride/iodide transporter. Well, that iodide is now in the colloid. It'll be attached to the amino acid tyrosine to make MIT or DIT, and those stand for monoiodotyrosine or diiodotyrosine, which means monoiodotyrosine means tyrosine plus one iodide. Diiodotyrosine would be tyrosine plus two iodide ions. Now, if you take the MIT and DIT and combine them together, so if you take one MIT and one DIT, that will make T3, which is triiodothyronine. If you take two of these and combine them together, that'll make T4 or tetraiodothyronine. We could just call that thyroxine. Know that T3 is the more active form. Okay, so T4 they're both active, okay, but T4 is definitely less active. T3 is considered the active form of the hormone. Now, T3 and T4, both of them, we mentioned that they're stored as colloid, and they are going to, in order to be stored, they have to attach to a protein, and they will be stored as thyroglobulin. Okay, so thyro is that hormonal part, and the globulin is the name of the protein, which is, yes, a relative of hemoglobin and myoglobin. So they're kind of like all of these proteins that help in attaching something and keep it storing it. Now that it's stored there, what happens when the body actually needs T3 and T4? Well, the T3 and T4 will leave that protein and will be transported through the follicular cell via transcytosis in order to reach the bloodstream. Okay, in target cells, T4 will be converted into T3. Okay, because again, remember the T3 is considered the more active form of these two thyroid hormones. So I'll take a look at this whole story in this image. So first off, let's understand what are we looking at. Right here is the capillary. That is the interstitial fluid between the capillary and the follicular cells. And this is the lumen of the follicle. This is where the colloid is. So we are looking basically at what is going on in this area between the follicular cell and the colloid. And we've added on there the capillary because that's where the iodide is. Iodide ions are found in the capillary and they have to be transported into the follicular cell. Remember we said they are co-transported with sodium. Okay, so now that iodide and sodium are both in, well, we have to get rid of that sodium, so it'll be kicked out through the sodium-potassium pump. And then iodide will diffuse through the follicular cell into now the lumen. That iodide is going to either make MIT or DIT, and through combination of those, we will end up making T4. They are stored in the colloid attached to a thyroglobulin. Now that when the body needs T3 and T4, okay, it'll pass through the parafollicular cell in a process of transcytosis. So transcytosis basically means you're going from one end passing through towards the other end. So endocytosis and then exocytosis. We combine them together and we call it transcytosis. And then your thyroglobulin obviously would have to leave so that we could secrete the T3 and T4 into the interstitial fluid and then off to the capillary and off through the bloodstream to their target cells. Now, what is the action of thyroid hormones? So you want to think of thyroid hormones as kind of like the perfect hormone for weight loss. Okay, thyroxine used to be actually sold over the counter for as a weight loss product, but thank goodness it was pulled off the shelves because it was actually dangerous, can lead to heart problems. And but it is a good way to remember the action of thyroid hormones. So first off, it has a metabolic action where it increases the basal metabolic rate. So BMR stands for basal metabolic rate. Thyroxine is the main hormone that produces energy and produces heat and is really important for your body temperature homeostasis. It is known as the calorigenic action of T3, meaning that it is going to produce calories. It'll produce ATP. And again, it represents a significant part of your total heat produced throughout the day. It's extremely important for body temperature homeostasis. And that's why you'll find when individuals have increased or decreased metabolism, that the first thought is, well, let's check thyroxine levels. Okay. T3 also stimulates carb absorption and it increases fatty acid release from adipocytes. So if you guys remember when we talked about the permissive action of thyroxine and epinephrine, we talked about how thyroxine helps the breakdown of adipocytes into fatty acids, releasing them into the system. There's the permissive action, and that brings us back to that. The permissive action between T3 and norepinephrine or catecholamines, which are norepinephrine/epinephrine, wherein, it's mediated because T3 is going to upregulate the adrenergic receptors in many tissues. So now that we have an upregulation of those adrenergic receptors, especially on the heart and on the nervous system, now epinephrine will be able to perform its function even better because it has more receptors to attach to. It is due to this action where T3 upregulates your adrenergic receptors, especially on the heart and nervous system. This has a lot to do with the clinical picture of a patient that has hyperthyroidism or the hypersecretion of thyroxine. You will find that these patients have tachycardia, they have high blood pressure, they have loss of weight, they are extremely hot, they cannot tolerate heat because of the calorigenic effect. Okay, so they have hyperreflexia because, again, we have increased the adrenergic receptors in the nervous system. So you see how, knowing the normal action of a hormone can lead us to understand the clinical picture, the symptoms and signs that are produced if there is a hypersecretion of that hormone. Now, the action of thyroid hormones or the effects and its effects on growth and development. So T3 is essential for normal production of growth hormone from the anterior pituitary. It is also essential, especially in utero, in the formation of axon terminals, in the production of synapses, in the growth of dendrites and dendritic extensions, and in the formation of myelin. So you could see how if in utero that fetus has hypothyroidism, their thyroid gland isn't making enough thyroxine, that would lead to a condition known as congenital hypothyroidism. And that is a congenital absence of T3 leading to the poor development of the nervous system. And you could now know why, because T3 is needed for the healthy development of the nervous system. And that can compromise the mental abilities. The good thing about it is that now we do what is known as neonatal screening for it. So we screen for levels of T3. They do have, though, a very characteristic facial appearance upon delivery, but we still screen for the levels of T3. And it is if screened and diagnosed early, it is reversible. So it can be treated with T4 at birth. Again, the baby will take the T4 and their cells will change T4 into its more active T3, and it will lead to, catching up onto their normal nervous system development. Now, a couple of things to talk about regarding the abnormalities of the thyroid gland. A goiter does not tell you anything about the function of the gland. It just tells you that this patient has an enlarged thyroid gland. So an abnormally large in size thyroid gland. So a goiter tells you about the size of the gland, but does not tell you anything about the function of the gland. Because that gland could be huge in size, but it is hypo-functioning. Different reasons for goiter, including endemic goiter. Endemic goiter means that it would be, since thyroid hormone is made through iodide, if somebody's not taking in enough iodide, let's say they do not eat, iodide is usually found in sea products. So for those countries that are far away from the sea or do not have enough sea products in their diet, that could lead to iodine deficiency, which can lead to endemic goiter. This is no longer, it used to be a public health problem, years back. It is no longer a problem because if you take a look at your salt, you'll find that a lot of the salt now is iodinized, meaning that they've added a little bit of iodine into it in order to prevent endemic goiter from occurring. Okay, so endemic goiter is due to iodine deficiency, where you could see the goiter will enlarge to try to make more thyroxine, but actually this person has hypothyroidism. So this is an example of how a goiter is just, by definition, a large thyroid, but does not indicate function. So endemic goiter, I'm going to show you the picture in the next slide, Okay, you can see this is obviously a very advanced stage, but in this endemic goiter, this goiter is extremely large. To try to compensate for the lack of iodine in their diet, the thyroid gland is trying to make as much thyroxine as possible, and that's why it enlarged, but function-wise, it is actually low. Patient has hypothyroidism. Now, another reason for goiter would be hyperthyroidism. So that person would have heat intolerance and weight loss. And we kind of talked already about the signs and symptoms and why that is. One of the most common reasons to have hyperthyroidism is an autoimmune disease known as Graves' disease or exophthalmic goiter, where the patient produces antibodies against their own TSH receptors. So they have autoantibodies against TSH receptors, and that again is known as Graves' or exophthalmic goiter. And I'll show you that image right here, which this lady right here. So you can see the goiter, the enlarged gland, and you can see the exophthalmos means the staring. So you can see sclera around, or the whiteness of the eye around the whole cornea, whether up or down. It's more prominent on the left side. These patients, as we mentioned, they would have weight loss, heat intolerance. Usually it happens, again, just like any other autoimmune disease, it tends to happen more in females. They would have menstrual abnormalities, GIT abnormalities, so diarrhea, weight loss, we already talked about that, tachycardia, high blood pressure, and so on. Now for hypothyroidism, okay, so again, they would have that goiter, but hypo-functioning one. They would experience cold intolerance and weight gain. The condition is known as myxedema. Okay, well, if the thyroid gland is just not making enough thyroxine. But the more common cause of hypothyroidism is another autoimmune disease known as Hashimoto's thyroiditis. So in this case, the patient is making antibodies against, again, their own thyroxine tissue, but now, or thyroid tissue, now they're destroying it though, leading to hypothyroidism. While in Graves' disease, these autoantibodies against the TSH receptors are actually stimulating them, leading to the hyperproduction of thyroxine. And here again, you can see this patient with myxedema. They have, that periorbital edema, the swelling around the eyes, the puffiness of the face, weight gain, usually constipated. If it is a female, they would definitely also have menstrual abnormalities. They cannot tolerate the cold because, again, they've lost the calorigenic effect of thyroxine. They would have low or slower reflexes, while this endemic goiter patient would have hyperreflexia. Okay, and at this stage, we'll stop here, and I will see you in the next gland.